Hello, everyone. Welcome. My name is Sarah Warren. I am a longtime urgent care lead PA in Lansing Urgent Care in Michigan. I am a senior medical editor at Hippo Education, and I'm a host on our new audio series, The Right Script and Antibiotic Stewardship audio course, which is now available. I'm more excited because I'm going to be the moderator of your webinar today, and we are going to be discussing implementing antibiotic stewardship programs in healthcare settings. I think everyone here knows that antibiotic resistance is a growing global health challenge. And for those of us working in clinical care, especially acute care or higher volume settings like urgent care, ensuring responsible antibiotic use is really critical to protecting our patients today and preserving these medications in the future. Understanding that problem, I think, is the easy part. The harder part is kind of knowing where to get started to fix it. And that's kind of what we're going to go over today. So, lucky for us, we are joined by two fantastic guests. We have Dr. Lindsay Fish, who is a medical director at the Federico F. Penna Southwest Urgent Care. And we have Dr. Paul Hansen, who is the Go Health National Chair of Clinical Quality. Each of these guests bring a wealth of experience in designing and implementing stewardship programs across really diverse clinical settings. And in a moment, I'm going to turn it over to them so that they can introduce themselves and share a little bit about their background and how they've approached stewardship initiatives in their own organizations. But I want to kind of give the layout of what's going to happen today first. So we are going to have a moderated discussion, and then we're going to have an open Q&A afterwards. We are going to get those Q&A questions from any comments or things you put in the chat attached to this live YouTube session. When we did our trial session a week ago to make sure technology worked, YouTube was having us have to sign in to leave a comment. So if you're trying to go in the chat and leave a comment and you're getting a pop-up box, it may want you to sign into your account. But as I said, we will save all those questions for the end. But that said, let's kind of get started. So Dr. Fish, I'm going to throw it over to you first. Can you kind of introduce yourself and tell us what your experience with implementing antibiotic stewardship programs has been?
Sure. So it's my pleasure to be here today. My name is Lindsay Fish, and I am the medical director at Denver Health's Federico F. Pena Southwest Urgent Care Clinic. So that is part of a healthcare system here in Denver. We're the safety net system. So we're a full healthcare system with a hospital and several clinics and urgent cares. And I am the medical director of one of the urgent cares. Additionally, I hold faculty appointment at the University of Colorado School of Medicine, where I'm an assistant professor of medicine. So I do quite a bit of research and education for our medical students and residents in the area of urgent care. In regards to antibiotic stewardship, I have the great honor of working with a wonderful team of people being part of both a university system and a healthcare system, but have really collaborated significantly as sort of our urgent care lead with our infectious disease doctors and our antimicrobial stewardship team here in our healthcare system. And I think one of our greatest successes that I talk about was a really simple initiative just to decrease the duration of antibiotic prescribing. So for various infections, we saw that many of our urgent care providers were prescribing, 10 to 14 days of antibiotics for something simple like a urinary tract infection. And so we had an initiative that we actually rolled out January of 2020, so 3 months before COVID, to really educate our providers that 5 days was enough for several common infections. And that showed a significant reduction immediately in duration of prescribing that has actually lasted throughout the COVID pandemic. But that's an example of one of the things we've worked on, and we continue to look at various antimicrobial stewardship things as well as others. It's not just stewardship about antibiotics, but lots of stewardship in steroids and diagnostic testing as well that we're working on in our system.
Awesome. Thanks for being here.
My pleasure.
Dr. Hansen?
Yeah, thanks, Sarah, and pleasure to be here as well. Dr. Fish, congrats on your recent UCA award. I was happy to see your name on this after seeing your announcement for that award, so kudos to you. So I'm Paul Hansen. I'm a med-peds doc that works in the St. Louis area, and I'm a physician researcher as well. I wear a couple different hats. My clinical practice is primarily urgent care. The healthcare system I work for, Mercy, is a large Midwestern healthcare system that spans across 3 states, Missouri, Oklahoma, and Arkansas. I have a variety of other appointments with Mercy too. The medical director for Mercy Express Care, which is a asynchronous model of care that I've done some antibiotic stewardship work and medication stewardship work with that. And then I'm also the national chair of clinical quality for Go Health. So Go Health is a large urgent care network that partners with different healthcare systems across the country. That's a fancy sounding title for Go Health's nerdy metric guy. So I proudly wear that nerdy metric guy hat. What that means in practice is I maintain and create different clinical quality metrics that we utilize in Go Health. And then I have a lot of touch points and work with different clinical leaders across those different healthcare organizations, trying to just show them what the best way to use the tools that we've created at Go Health to be able to maximize their time and their effort and resources as clinical quality champions local to their markets.
Awesome. I am okay if you're the data guru for this talk, or the data nerd, I will say. Let's go ahead and start things off really with the beginning, which is, where do we begin? So if I'm an organization right now thinking about the first practical steps in launching an antibiotic stewardship initiative, where should I start, or what should I be thinking of? Big bolt type items, Dr. Hansen.
Yeah, so I think really just wrapping your head around the why. So why is this important is really the first step in this process, because at the end of the day, if you're passionate about it and you understand the why, selling people on selling other key stakeholders on why this is important becomes really easy. So we're trying to improve care, we're trying to reduce the incidence of C. diff. Delivering high value, high quality care is important to us as a group. If we become the urgent care, or if we become the clinic that's known for delivering that high value care, ultimately it might end up driving volume to our group versus somebody else's group that doesn't have that focus. So I think really internalizing that why is step one with this work. And then you got to start building out your team, I think, is the kind of the next practical step. And so identifying who's going to be, key stakeholders, really getting top down buy-in is important. The next step, which is my favorite part, is the kind of the data element portion of that. So getting kind of a baseline data grab or audit just to kind of see where you're at and see if there's any easy wins that you can implement. And then last step would be, once you kind of have that baseline data and kind of have a plan of attack, introducing this topic to your group, specifically your provider group, but I would just include all the clinical staff in that messaging, and really that helps to build and foster that approach that antibiotic stewardship is going to be something that we're going to get buy-in from every single coworker that works with our group.
Yeah, and I absolutely agree. I mean, I think the pieces, just to add on to that, is sort of, when you build the team and get baseline data, you do have to think about what you're going to strive for based on that data and what that team is willing to have be a why. And so there's lots of people with lots of different ideas, but getting people on board with something or particular metrics or such like that is going to be really important. I always, use the antimicrobial stewardship of, drug, yes or no, meaning should you be giving the antibiotic, but or you can look at drug choice, duration, and dose, right? And so all of these are aspects of this approach that you can look at. I gave the example of a duration approach. Lots of people do, should you give the antibiotic or not, right? What is the right drug approach? And so kind of really thinking about what those metrics are, and that may be, to Dr. Hansen's point, based on what metrics you can actually pull, relatively simply from your electronic health record for your provider. And then I think, thinking about it kind of moving forward with your team, but really creating a stepwise plan for implementation and what it's going to look like. Not just do this, but what education are we going to provide? What support are we going to provide? What EHR changes can we make? And those components. And then lastly, what's going to be the incentive to the why question? Is the incentive, financial, or is the incentive just, we're here to provide good quality care and we're all just going to do the best we can? Kind of an intrinsic motivation are all really key factors too.
Dr. Fish, when you talk about getting that team together, that initial team, are you talking about a provider and an admin? Are you talking about how many people are in this team, and how do we make sure the team's successful?
Well, I think it can look different based on your organization. I think there needs to be a champion. So there needs to be a team leader who is a champion, who is going to take responsibility for this initiative and moving it forward. I think, in our organization, I mentioned sometimes it's an infectious disease doctor if you're part of a large organization, or it's a chief medical officer or a quality person, or maybe there's someone who's running one of your clinics that just really cares about this and can kind of be the champion. And so I think it's about a team leader. But we've mentioned many of the components. You're going to need providers on board, right? If it's going to be a provider-based initiative, you're going to need your EHR people on board who are going to be able to pull the data. And so you're going to need some of them on the team to be able to kind of be a part of the data. If there's going to be a financial incentive, you probably need an HR person on board to be part of the team. And so I think the team can be a mix of various people, kind of depending on what, sort of your champion or leadership really wants to sort of be the initiative and what it might look like.
Have you found any like quick wins or low lift challenges that help us kind of build that early momentum that maybe we could build in?
I think one of the best quick wins is something that's an easy resource for people to use, and quick feedback. So I think those are the two things. So one quick win is, this is the focus, this is what it's going to look like, and here's how simple it is for you, and have an easy reminder for people, because then people are sort of seeing it, reminded to do it. And then really quick feedback. One way to definitely lose momentum is to be like, we're rolling out this project, and then 6 months later we talk about it again. And so it should be, if you're pulling data and you're looking for changes, it's every month data, and it's keeping it sort of live and active. I don't know. Do you have other thoughts, Dr. Hansen?
No, I think that's great. I think a lot of times trying to decide like what could be an easy win, a lot of times that can go to when you're looking at the data initially, like does something stand out? It's like, oh, looks like our group is using an awful lot of quinolones. That's kind of surprising that something like that could focus your, here's a quick, easy win that we're gonna grab initially. Versus are we using the right antibiotic for a particular diagnosis? So if you're looking at it, different ways to slice the data up, if you're like focusing in on pyelonephritis diagnoses and you see that there's some nitrofurantoin use there, and that could be okay, this is a nice quick easy win for just a quick education point, and that should be an easy way to track that data and improve that one particular data point.
Dr. Hansen, this is data, so I'm gonna send it to you first, but when we're planning this process and getting the data together, are there any key metrics or tricks or tips you may have that we may want to track?
Yeah, so I think a good place to start, number one, is nobody has to do this from scratch like this. There are so many antibiotic stewardship toolkits out there, and a lot of them, they vary in their level of detail, but some of them are very detailed. And so like if you're not the data person, but you're very passionate about this, there are very detailed how-tos that you can pass along to your data team in your healthcare system. So I think that's one important point. The CDC's really got a great tool that compares the pros and cons for all these different metrics, and different metrics have, might be easier to build something to track, but then they have different cons to them. Some of the more complicated, like compound metrics that include a bunch of different exclusion criteria and stuff like that, might be more of a lift from a IT team support. But if your healthcare system has those capabilities, those metrics tend to be potentially less gameable. So there's, like I said, going over those pros and cons. I really think the simple place to start, like how many antibiotic scripts are going out, what antibiotics are you using, and then what diagnoses, like primary diagnoses, are those things being used for? Those kind of are the three points. And you can include, by clinic and individual providers, and so design in a report to just pull that kind of baseline data to see where you're at. It's a good place to start.
Yeah, I mean, certainly one of the biggest, urgent care specific studies on that was exactly to your point, Dr. Hansen, right? The overall prescribing rate of antibiotics. And that was the Steinem study out of Intermountain Health, where they really did a full comprehensive intervention. And that was a really big overarching goal, right? Is sort of just look at it across the board and make those numbers go down. And to your point, right? That's antibiotic, yes or no. But I think you can look at other metrics to the same point of, specific to a diagnosis, as you mentioned, pyelonephritis, pneumonia, UTI, sinusitis, otitis media. All of those are very common diagnoses that you see in urgent care, and you can see great variability in what drug is prescribed for any of those, the duration of those drugs, and the dose of those drugs. Are you using Keflex 1000 or Keflex 500? For example. And so, are you using a fluoroquinolone or are you using cephalexin? And so you can look at kind of all of those different aspects of it. So I love the 4Ds, right? Drug, dose, duration, and then, are you doing it at all? That's the disease part, right? Are you making the right diagnosis? The other thing some people tend to look at too, which is a little more complicated, but can be done, is the idea of a delayed prescription, and looking at delayed prescriptions for antibiotic prescribing, which is another, potential metric that's relatively I think that can be harder to do, but again, depending on your electronic health record and how your prescriptions are being written, that may be something you could pull as well.
It sounds like from both of you, there are so many options. You kind of have to pick. Like maybe you pick based on the data, maybe you just pick we're doing duration and then go across the board. When starting the programs for both of you, did it expand? Did you start it and then expand? So pick one drug and then kind of roll out things slowly, or how fast was that expansion from where you started to where you added new keys and new goals?
Well, for us, our antibiotic stewardship data collection had been live since before I had joined GoHealth personally. And so that had been a program that had been up and running for a while. And so a lot of my work on that was, improving how the data was captured and the quality of the data that we're getting, and then adding some additional tools to allow for that more deep dive of, specific diagnoses. So you get to those additional data points to drive those individual projects as people got interested in those in individual markets. I'll say I have also been a part of, not through GoHealth, but as my through Mercy healthcare system overall. I was a part of helping them build an outpatient a dashboard for outpatient antibiotic stewardship. So all of our healthcare systems focus had been on, inpatient antibiotic stewardship. So there's a lot of times there's a lot of resources dedicated to that, but not as much in the outpatient space. And so going through the process of building out one of those kind of more complicated dashboards, and those take time, and that can be a bigger lift and a bigger ask. But then the nice part is once it's built, it's there, and then you can start getting people to buy in, saying, hey, we have this data on outpatient antibiotic use now. That's widespread across our entire healthcare system. Let's get buy-in from the infectious disease and primary care, family medicine, on how we can start utilizing this data to improve the care that we're delivering.
Do you guys have any tools, data analysis, platform type things that you've used in your own initiatives that may be helpful in tracking this data?
Yeah, I think it's going to definitely depend on your electronic health record. And I, like Dr. Handsome, am on Epic, which is a great platform. I'll let him speak a little bit more to Epic. But I think in general, you want to think about, we sort of talked on side, right? If you're going to look at the drug, the duration, or the diagnosis, if you're going to want to look at those, versus you can also look at sort of the other side, which is by clinic, by region, by provider. And so you could sort of look at it different ways depending on what metric it is that you're looking at. And I think, again, that will depend on your IT capabilities and resources and what platform you're utilizing.
Yeah, and so I'll take it from there. So I am lucky in my healthcare system, my particular healthcare system, we also utilize Epic. And so there's a tool that's embedded in a lot of instances of Epic called Slicer Dicer that could be really, really useful for a lot of this data, initial data gathering, after you kind of get the idea of how it works and you're able to design your own report. So it's a self-service analytics tool that really lets you quickly design and pull your own custom reports without having to put in a request to somebody and then wait a week or 2 weeks for them to get data back to you. So that could be very helpful for healthcare systems that have that tool.
Once you get this initial data and you launch whatever initiative you're going to launch or whatever you're going to focus on, how often would you guys recommend that we're reviewing the data or going back and pulling it again and seeing what effect or change we've had?
So I think Dr. Fish hit on it earlier, but I think at least monthly is probably a good place to start. That you're reviewing and tracking and looking for early momentum, early improvements. If you have too far time between when you're reporting this stuff out to your group, people might forget about it, forget why it's important, why we're focusing on it in the first place. I do think probably the goals that you set, having again thinking kind of short term, midterm, long term goals is not a bad way to go about it, but kind of short-term goals be like one or we're here, we're this number and we want to see this improvement over the next 2 quarters, and then you continue to report that out to your group on a monthly basis.
I would add the piece of that is, again, to be cognizant of what you're looking at. July, looking at prescribing for pneumonia is probably not the best time. You're not going to see probably significant change in a month if you look just over the month of July versus if you were looking at antibiotic prescribing for pneumonia in January. So, you do sort of need to be cognizant of some seasonality, with sinusitis and some of these ones that are more common in sort of our respiratory season. So being aware of that, because that's a great way to fail, is to pick an initiative that you have a very low prevalence of in the community at the time you roll out the initiative, and then you suddenly come back and kind of people are thinking about it, but they're not, but now you've shown no change, right? And so your team that's championed this have put all this effort into, educate, put signage out, change, stuff in an EHR, and now we've pulled our first month data and it did nothing. Well, that's because you didn't, sort of select appropriately, what your initiative was going to be based on time of year for seasonality for some of these things. So I agree. I think monthly is probably a way to go. Most organizations, most groups have monthly meetings. So it'd be a really easy way to sort of have 5 minutes to give an update on a project, right? You maybe roll it out the next month, you're giving its first update, but don't pick something that's going to fail because it's the wrong time of the year. And recognizing that things change, right? I mean, it takes us a while to get these things up. So you probably start it in the summer and think you're going to get it up in January, and now it's July, probably not the time to be sort of rolling out, tell everybody they've done nothing better after rolling this out, for example.
Great point. I'm going to kind of switch gears for us a little bit in a piece that I think is the hardest, but maybe you guys have found it isn't, which is once we start the initiative, how do we get the providers to buy in? How do we communicate? What are strategies there? Because really they need to be all in to make the changes, right? So what strategies have you guys found that work without overwhelming your clinicians?
Yeah, so I think the first thing is keep it simple. I mean, we are busy, our brains are full. Like, you've got to really keep it simple. And it can be very overwhelming, to Dr. Hansen's point of, you're going to probably create a larger antimicrobial stewardship plan. And so but this needs to have short-term, midterm, long-term goals. And so rolling out the long-term goals on day one is really going to overwhelm your clinicians. And so I think one is to keep it really simple. Where it's very clear, do this, not this, right? Or our goal is do this, right? So whatever that might be, don't prescribe an antibiotic for bronchitis. That's a very simple goal, right? Or, for a UTI, prescribe for 5 days only, not 7, 10, or 14. And so being very simple on kind of what the goal is so that it can be really, really easily reiterated. I think if there are easy ways to remind people, we had little cards we posted at every desk that just said, take 5. And it was just a simple card to remind us to prescribe 5 days instead of 7, 10, or 14. So really simple reminders that are right there for people to sort of see. If you can create them in the EHR, all the better, right? Have your order default to 5 days, not 7, 10, or 14, when you go to want to order these prescriptions, or have an order set. So if somebody selects UTI, it picks, nitrofurantoin or cephalexin as opposed to the fluoroquinolone, right? So I think thinking about ways to make this simple and easy for providers is really important for our clinicians to make good programs. I think the second thing that I always tell people is, a lot of our clinicians, just feel this pressure to prescribe antibiotics. Well, the patients want it. The patients want it. I once had someone tell me, this is the best thing I ever heard. Whenever a patient comes to urgent care, they want a door prize for coming to urgent care. But they actually don't need what they think they need. They just want the door prize. And so the answer isn't, I'm not giving you anything, right? The answer is, let me give you something to help you. And maybe that's cough medicine, right? Maybe that's a decongestant, or something for your symptoms as opposed to being like, there's nothing to do, right? So I do think that's a simple thing, but that really helps with the patient piece. Certainly there's lots of great programs outside of this that, educate clinicians on how to talk to patients about antimicrobial stewardship, the risks of antibiotics. Those are all wonderful, but I think most clinicians feel like that takes a long time. And I find it's a lot easier to just say to a patient, I know you don't feel well. No, azithromycin isn't going to work for this, but you know what will help? And say something and give them something for whatever their actual diagnosis is. And then I think really engaging clinicians means you've got to keep it on the forefront. Back to the idea of it's got to be a regular part of your meetings, your education, your sessions, and sort of have it just become part of the regular discussion that we're having with our clinicians.
Yeah, I think that's perfect. I really, making it a part of the culture is really one of the really important things that keeps it. I think that's one way to keep it from being overwhelming too. Like when somebody comes into the group, they realize, okay, this is everybody's on board with this idea of antibiotic stewardship, and that's really a great way to keep people engaged in that process, especially if it's somebody that's coming in new from a group that didn't have that focus before. One thing that's also really helpful for us is like being able to share like a provider's personal data with them has been really effective for us. And really it allows us to tailor that feedback specifically for that provider. So like this is the, here's your numbers, here's kind of how you've been prescribing things versus other providers in our group, and what can we learn from that. That is also really, really helpful. To the point that Dr. Fish made earlier of like keep it simple. Don't overwhelm folks with like trying to cover an entire curricula of stuff in like one setting. Like there's with all those toolkits, there's a lot of like one pagers based on the diagnosis that's already available, so you don't have to create that educational material from scratch. And you can like spread out those different educational tidbits or PowerPoints that are already pre-created and kind of customize it to your group. But you could spread that out over, several months, so providers aren't feeling overwhelmed.
Have you had any issue, I guess, feedback from providers where they feel like you're policing them or dictating what they do? Or in general, is there any way to avoid that, or has it gone over pretty well?
I think that goes to building that culture, so that keeps it from feeling like it's policing. We're like guardrails to support. We're not sitting over somebody's shoulder being like, why are you writing so many Z-Paks? But really having it more of as a guardrail can be really helpful. And I think offering meaningful support in terms of like communication strategies, so that can go a long way. Of I find that running specific patient scenarios with folks can be helpful, and having tools to help coach providers that may struggle with those more difficult conversations around antibiotic stewardship. The parent that just wants their antibiotic for their kid that's sick with a URI, helping them kind of walk through how to approach those scenarios based on really finding a way you can align your goals with what the goal of the patient or the parent is.
Yeah, the other thing I think, which can be so hard in urgent care, is just recognizing the bigger picture. We frequently forget because we don't see them back when they have these side effects, right? So antibiotics, can have side effects. Up to 30% of people can experience a side effect from an antibiotic. And we don't always see that, or if they do come back, it's not always the same clinician that sees them. And so, for me, I really frame it as quality care. And to the culture piece, it's not just a culture of antibiotic stewardship, for us, we're a culture of learning all the time. I've been doing this for a long time now, and I still see things and I still learn things and things change. And so for me, I just frame it as we're all in a place of trying to continue to learn and improve, and an effort to learn and improve, the care, that we give to our patients. And that's medicine, right? I mean, if medicine didn't improve in the last 100 years, we'd be in a very different place. And that's part of healthcare and medicine. And so this is just part of it, is to continue to sort of have this be a culture of learning and growing for us and ourselves and our patients, and have it be like, I noticed that you're different from other providers. And not that I'm saying you're doing it wrong, but I'm wondering where it comes from. And, and then you'll have a conversation with a clinician. They'll be like, well, I've been doing this for 30 years and that's how we did it. And I was like, well, that was 30 years ago, and things have changed. And, we really need to, and it's not a criticism. They've practiced great medicine for 30 years, right? But things have changed. We've learned more. And so I think just really having it be from that place of, my job is just to help support you and help you learn and grow so that we can continue to provide the best care to our patients.
Have you guys, either of you, tied some sort of incentive to these programs, whether it's financial or performance-based? And what advice or what feedback can you give us on what that may look like, or any troubles you've had with that?
I'll start. I work for a safety net. We're very poor. The answer is no, we don't have financial incentives in our institution because we're a very mission-driven institution. So I will say, no, we have not done that. So we have to do much more to the culture piece. Dr. Hanson?
Yeah, so we have, and just kind of stepping back from antibiotic stewardship and thinking about medication stewardship and delivering good care as a whole. So we do have financial incentives that are tied to our antibiotic stewardship piece, and that can certainly be helpful. One point to make is, playing to, providers are naturally competitive. There's a subset of providers that are, tend to be more a competitive bunch. And so you can utilize that to your advantage, without any sort of financial incentive, just by utilizing, here's our goal, here's where you're at. And so there's a fair number of providers that'll change their practice just based on that competitive nature of wanting to be the best or wanting to improve the care that they're delivering once they have the data that they need to be able to act on that. Backing up to, I think what's really important, if you do tie financial incentives to these, there are a subset of providers too that once you tie that financial incentive, they'll go that extra mile to help meet that whatever goal you set to hit that benchmark. But you really got to think through how that's going to play out. Like, at the end of the day, people are going to pay, they're going to do what you pay them to do once you start tying money to it. And so making sure that what you're tying money to leads to what you want it to. Like, what you're wanting to incentivize is great high quality care, not just necessarily a number improving. So you just got to think through all those points, and be thoughtful on the front end when you're thinking about tying any sort of financial incentives to these.
I'm going to move on to our next topic. So what has worked well and what hasn't worked well, in terms of your metrics, but are there any specific examples of success stories you guys have? And I'll start with you, Dr. Fish.
Great. Well, I think I mentioned briefly at kind of our Take 5 campaign, which was our effort to reduce the duration of antibiotic prescribing. And we basically had an initiative. We looked at common infections seen in urgent care: sinusitis, UTI, pneumonia, otitis media, for example. And we basically initiated a campaign of saying, hey, for these infections, 5 days, the majority of the time is enough, right? I'm also not 100%. There's always exceptions to the rule. There are always things that we need to recognize. The goal is never 100% because everything is different for patients. But we certainly know that the majority of the time, for these infections, 5 days is enough. And so that was a very simple concept, right? Just prescribe 5 days, not 7, 10, 14 for these 6 infections. Our campaign, as I mentioned, rolled out January of 2020 with an educational session to our providers. It was literally a one-time session. We did add the little reminder cards that was placed at every workstation. And then we did update our Epic, so it would sort of default orders to 5 days duration to make that simpler for our provider. That was pretty much the intervention because COVID hit. done. We all were dealing with other things at the time. And so it was really an interesting sort of thing. We weren't sure. We kind of looped back after COVID to kind of look at this. And basically what happened was we had an immediate 10, almost 11% increase in prescriptions for less than 5 days. And then that sustained over time with continued sort of increase in 5-day or less duration and a decrease in more than 5 days duration. And I think, you know, that has continued. We're now nearly 5 years later from this campaign. And obviously some of the things are still in place. The sort of the Epic the Epic orders are still in place that way. But I think what's amazing about that is to look at, that has resulted in, in our location, just, hundreds of thousands of fewer days of antibiotics in, this type of a setting. And so that's made just such a big difference in our system. And now to the point of culture, that is just the culture now. The culture is you should have a reason to prescribe more than 5 days, right? So it sort of just transitioned our culture to sort of saying, we all just think 5 days now. And, sometimes now we're thinking maybe even 3, and maybe there are some things for that, but sort of certainly none of us are walking into UTI thinking 7, 10, 14 anymore. We're all thinking just 5 days. So that's an example of one of our initiatives that was really successful and was very simple, right? It was an educational session. It was little reminders. And then, like I said, we were able to utilize some changes on our ordering system in Epic to make that simpler for our providers. And then COVID hit, but it still worked.
I think that's great. I love that. I think you're underselling how impactful that, updating the EHR, those darn presets, like why are they set to 7, 10, 14? Getting those updated, it could just have a huge impact once you make the path of least resistance for the provider to be the right one. That change usually seems like it has a meaningful and lasting impact. So kudos to you all for doing that hard work to get those changes done in the EMR. For us, I've noticed that our biggest, our most successful intervention is our clinical quality scorecards, automated scorecards that go out to every provider in our group that has their personalized data on it. So that's sent out on a monthly basis that goes. We've noticed that when that initially went live with the antibiotic stewardship, that their antibiotic stewardship numbers started to drastically improve shortly after that went live and started going out to all the providers. Similarly, we've done something more recently in the last year and a half or so with a steroid metric, similar sort of thing. Once the steroid numbers started going out to all the providers, that coupled with education that we were sharing with all the provider groups, started to see a pretty dramatic improvement in our overall steroid rates and the steroids that were avoidable that we've seen. So that those really getting the data for us in an automated way to the the boots on the ground has really been a very successful intervention for us. Another thing that I like to really preach is we talked about how important the clinical quality champion is earlier, but their time is a finite resource. And so thinking about how can I maximize the clinical quality champion's time and especially their individual, like one-on-one interventions, I think is a really important point. And one point that I think that we found that's been helpful is if you have a list of providers, like if you're a part of a big group, that list can be very long, hundreds and hundreds of providers that you have, and then you have their performance on whatever particular metric that you happen to be tracking. If you just sort by their performance in that metric, you'll get a list, and if you approach it from whoever the lowest performer is on that metric, you'll have an impact. But you have more of an impact if you also take into account like what sort of volumes is this person seeing. So you're targeting the high volume low performers is really the key to maximizing that clinical quality champion's impact in a market. And so that's been another intervention. I'm still trying to get that built into our dashboards to have the data displayed that way. But for now, I try to take time with all the clinical quality champions that work in our various markets to show them how to tinker with the data a little bit to get your list presented in that way.
Have you guys found any interventions that have either backfired or been more challenging than expected?
Well, one I'd say is a work in progress for me is I mentioned earlier I'm a huge nerd. So I had I understanding that clinical quality champions time is finite, and their ability to like be in the room and do like direct observation of patient interactions and then give feedback, like that's a very labor intensive process. And we as clinical leaders try to fight for them to have the time to be able to do those sort of things, but there's just not enough time in the day to be able to give that sort of feedback to everybody. I ended up building a antibiotic stewardship communication chatbot so you could practice these scenarios with pretty much ChatGPT runs through these scenarios as like a patient or a parent. They kind of escalate in difficulty, and then it'll also switch to give you feedback on your communications skills and strategy and offer like specific points for feedback. It seems well received for the folks that have used it, but just how to best implement it is still something that I'm trying to work through. So if I was smarter, I'd build it into a website, but
I would say the other big thing that just is such a challenge always is just fatigue. Like everyone's tired of hearing about antibiotic stewardship, just like everybody's tired of hearing about COVID. And so I do think that it is a challenge to continue to keep people engaged and interested and, kind of finding new ways to do it. Because I think we're all tired of hearing, don't prescribe so many antibiotics. And so I do think that that's a real challenge for leaders and people in this area to sort of really be able to keep momentum, interest, and people engaged in it.
Have you guys found anything that works for continuing that engagement? I know we're doing, monthly email reminders, so it's on top of mind, but is it really just talking about it over and over again that seems to keep that engagement or prevent things from becoming stale?
Well, I don't think you just want to talk about it. I think that could make the fatigue worse. I think it's about really celebrating successes, right? And sort of acknowledging where the successes are. So it becomes an area of reward, if you don't have financial incentives, right? If there's financial incentives, that can kind of keep things more engaged for people because they get something at the end. But for us, it's about really recognizing the people that are excelling in these areas and really acknowledging them and giving them sort of, some kind of recognition for that. And that then we as a team collaborate to celebrate. And that keeps the momentum going as sort of, we're a team working together, but this person's really excelling. And that sort of drives the next person to keep excelling. And if somebody else who struggled really has made big progress, we celebrate that progress. And so it's not just about don't prescribe antibiotics over and over and over again. It's about really saying, hey, great work in this area. Da 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 da. This has really come up. And now we're going to like raise the bar because you guys are so amazing. And we're going to add this piece now. And sort of really framing it and how you frame it, I think, is critically important.
I'm going to switch over to our live Q&A. So we have some questions. So these will be kind of new topics for you guys. So the first one we have is, when thinking about starting an antibiotic stewardship program, is it best to start broadly, for example, number of antibiotics prescribed overall, or pick a specific condition like bronchitis? And we touched on it briefly, but do you guys have any answer or feedback on that?
Well, I'll counter. I'll add, because Dr. Hansen sort of said start broadly, and I actually think that is the better way to go if you haven't done anything. I think there is just too many ways to manipulate specific things in our system, whether we want to admit it or not. You just suddenly pick a different diagnosis when you decide you want to give antibiotics. And not that anybody is doing that. Of course not. We're all giving the right diagnosis and the right treatment, but I'm being honest. So I actually think when you begin, an overarching big picture of where you're at is really important, and then sort of narrowing from there. Even in my example, we picked duration, but we picked duration looking at 6 different things. We didn't just pick one particular illness to look at. I don't know if you have something to add, Dr. Hansen, but I think my approach would be broader.
No, I totally agree, and that is one of the pitfalls of if you just pick to focus on one particular antibiotic or one particular like diagnosis. That might fall into the easy win category, but if that's all you choose to focus, then you can run into issues with like diagnostic shift, where people are just shifting their diagnoses around rather than actually changing the care that they're delivering. So that's a valid point. But utilizing that kind of initial audit can help drive of, okay, maybe we can start with an easy win, but then our overall focus is something more broad.
Have either of you seen any changes in patient satisfaction scores or revisit rates after implementing stewardship programs?
So we haven't found that there's been any like reduction in patient satisfaction scores with implementing these sort of programs. And I think the key to that is just your communication strategies that you're utilizing. And so that's why stressing that those interactions with the patient, and getting essentially your spiels down for these different common scenarios that come up, and how can you approach those and tailor them to the specific needs of that particular patient, really help drive that. At the end of the day, the patient's more likely to do implement the medical advice that you're giving them if they're satisfied with the care that you delivered. So being able to achieve both, I think, are equally as important.
And I agree. We've seen no change in patient satisfaction scores. And I'll add that in our study on the 5-day duration, there was absolutely no increase in return visits. So decreasing that duration of treatment did not cause an increase in return visits to the second half of that question.
You guys work in bigger systems. How do you manage stewardship initiatives across multiple clinic locations with different cultures or different provider personalities, so that wider net?
So for us, it's important to have the local clinical quality champion, the boots on the ground in the different markets. Is really they're the ones doing the hard local work in that area, and my job is to support them and help them understand how to best utilize the tools that we've built for them to be able to be successful.
Yeah, and to that point, I'm a larger system. We used multiple urgent cares on that Take 5 campaign. And so myself and the other medical directors from each of the other urgent cares were involved in the implementation process. And we were able to tweak it to our different sites. So for example, one of the other urgent cares did not want to have the education session. So they did not have the initial sort of education session that I wanted to have for my clinic that I felt would suit. So that's a very simple difference, but it wasn't a one size fits all, even for us within, not even multiple states. We're all in Denver, and we had different approaches based on sort of what leadership at the different urgent cares felt would be best for their teams.
Have you guys found that different types of messaging resonate more with newer providers or new grads versus seasoned providers, or does it seem to be everyone kind of responds to similar interventions?
I mean, I feel new grads or people that are earlier in their career, seem to be more appreciative of, tying in clinical pearls with any sort of particular clinical intervention that you're or coaching that you're offering, so that could be a reasonable way to go about it. But I think Dr. Fish utilizing that example of the provider that's been practicing for 30 years, might be a slightly different approach that you take. I like to take into the experience into account, and maybe tailor it more towards it. Do we need to focus on an education gap if there's somebody that's newer? But really looking at, I kind of tailor the particular counseling based on what's kind of the profile of this individual provider based on their kind of overall numbers of the things that we keep an eye on. And so is it somebody that's their NPS is struggling, or their patient satisfaction is struggling, and their antibiotic rates are high, in which case you kind of tailor that, how are these interventions going? Are you trying to utilize antibiotics thinking it's going to improve your satisfaction scores? And so you can get to some specific feedback based on those, kind of looking at those different data points of what their overall antibiotic use is, how their patient satisfaction is doing. And then for us, we track the inappropriate antibiotic rate. But if you were utilizing a shorter duration or something like that, it could be a similar approach.
Do you think sometimes there is some nuance generationally which, generally new grads are younger, but that's not always the case. But I do think there is some nuance generationally about kind of what motivates the different generations of workers, and really being cognizant of that. You know, there are some providers, some sort of, culture where, any feedback is considered negative feedback. They're going to be personally affronted by this. It's not going to be seen as coaching, even if that's how you mean it. So really, tailoring sort of these programs and how that individual feedback is done and coaching is done is really critically important to the person, who they are, their motivations, and potentially, generational. The Gen X's are different from the millennials and such. So I think that's a real thing we sometimes see.
Okay, Dr. Hansen mentioned diagnostic shift. If I'm looking at the data, what might that look like? Is it just someone getting better all of the sudden, or what should we be looking for?
Yeah, so that would be so that's if you're choosing, when you're looking at kind of what data do you want to track to try to improve. If you're looking at something that's like a single diagnosis that's specific, or if you're looking at like a group of diagnoses that are just for things that you've determined are inappropriate for antibiotics in this case, the risk there is that providers will just change their diagnosis patterns as they learn that metric. So if you just focused on only bronchitis, they might just change and not diagnose bronchitis anymore, but then their antibiotic rates don't change. And so that's the basic idea of what diagnostic shift could be. And the degree of shift that you have kind of depends on the metric that you implement. There are ways to, track that as well. And so that's one of the tools that I built for our healthcare, for our group of urgent cares, as a metric to be able to track and kind of keep an eye on, is the diagnostic shift on an individual provider basis, getting a little out of hand for particular providers. But essentially, you'd expect the overall antibiotic rate to potentially be really high, and then the inappropriate antibiotics that you're looking at to be really low.
I have one final question for you guys. If you could sum everything up, what advice would you give other clinics based on what you've learned, or just a couple key points to tell everyone who's listening?
Yeah, so I guess I can start with that. I think step one for me, my main take home would just be, don't be scared of the data. It's not as scary as it looks. It's fine. If I rewound myself 10 years ago, I had no research interest. I didn't care about spreadsheets at all, and so it's not anything to be scared of. And then there's no need to start from scratch. You're not having to build your own antibiotic toolkit. You want to tailor it to your group, but there's lots of places to start from. So the CDC, the AHRQ, and like the UCA, UCF all have great toolkits to start from. And then the last point is just being intentional, especially when you're kind of looking at your initial data, like pre-intervention, about what do you want to choose to focus on, and thinking through that process of how that'll change.
I'll add to that. I think, sort of those were all really high level things. I think it's really about boots on the ground too, and who's going to be your frontline boots on the ground, really carrying this forward, having those, doing those education sessions, providing those individual feedbacks, introducing this new metric to everybody, and how is that going to be framed. And so I think, having the right people and finding people who are interested and engaged and want to sort of take this on, is going to be a much more successful way to sort of do all the stuff Dr. Hansen just mentioned, and really make it be effective for your clinics and patients.
Thank you guys so much. You guys were amazing. Thanks everyone for joining us. I was going to say, really, we can't do it without all of the help. We all have to start somewhere. And so learning from someone else who's already done it is helpful, I think, to everyone. So if anyone out there would like to hear more, I highly encourage you to check out our new antibiotic stewardship course, The Right Script. But thank you for joining. Thanks for your time and commitment, and we hope to see you at future discussions.